social gatherings were there. So how they have taken similar kind of things happened in Israel also. So he has shown that how those has impacted in the prolonging the virus spread into Israel, and finally they have shown through their model that now Israel is almost free from vaccine, and which they have very nicely mathematically modeled, and Israel is now mask free. So but in between that, after that, they have shown that very particular thing about the India, that what is if the vaccination program is not taken 10 times that what we are giving now, then the peak will not be peak time that according to their model, the kind of vaccination program is going on. It will be something like in September. But if we increase, which we know that how to increase, what are the efforts are going on, even from the state government, they are going for buying vaccine. They are now making international tender to get the vaccine and many other equipments, because it is health is a state subject. So in that way, with the kind of effort that India, various states and UTs are taking up, so there is every hope is that whatever rate of vaccination is going on, we have to increase it by 10 times, 20 times. So their model also saying that if we are not increasing it to 10 times or 20 times, we will not be having a so easy way out from the virus. So with that, we had the first day of the 3-day session, and now we are open for second day. Okay. Oh, yes. Yes, Rupak?
Yes. I would also take a moment to welcome Dr. Ritupriya. Thank you so much, ma'am, for joining us again today afternoon. A very warm welcome to you. Ladies and gentlemen, Dr. Ritupriya Mehrotra, she's a professor of Center of Social Medicine and Community Health.
It is social science. She is from social science.
Yes, School of Social Sciences. Yes.
School of Social Science.
Yes. School of Social Sciences, the Center for Social Medicine and Community Health, School of Social Sciences, JNU.
Yeah.
Very warm welcome to you, ma'am. Thank you so much for joining us today afternoon. We're really looking forward to hear your thoughts and your experience on this subject, where we primarily are talking about the second COVID-19 wave, and also the biggest challenge which it has thrown upon us is on the logistic supply chain management. And one of the hot topics which the world is talking about, in fact, especially in our country, is the vaccination drive, which is going on right now, full throttle, amidst so many availability issues, supply chain issues, of course, and which vaccine is safe or not. People are sort of contemplating, speculating, on different types of vaccinations. And we have an expert amongst us, Dr. Ramachandra Kamath, who's professor and head, Department of Community Medicine, Kodagu Institute of Medical Sciences, Karnataka, who would be speaking on this subject in detail, letting us know more about what we need to know, we should know, and help us also demystify, issues which have been a question, a point of concern over the last few weeks. We all are very excited. We already are over 250 in number, Dr. Kamath, and I think this is the right time now to hand it over to you for your presentation on COVID-19 vaccine. Over to you, Dr.
Very good afternoon. Thank you, Dr. Ghosh and Dr. Sood. This is the very right knowledge sharing platform, and it is on right time. So I'm very happy to share knowledge, whatever I have regarding the COVID vaccine. So always when during this pandemic, I think we had a lot of issues, so many problems, socially, economically, health issues. Okay, so and COVID coronavirus has really shown us, okay, so where we are, and health systems, because whether we have adequate or not, our lifestyle is good or bad. Okay, so I think most of the things we have learned because of this coronavirus. Always when we talk about a vaccine, I think this is the very key tool in ending pandemic. Okay, and normally it takes many years to develop, but during the corona pandemic, so I think we were all in the fast track, and the vaccine came, and as we know, we are the second largest population in the world, and even seeing this vaccination campaign, this is the largest vaccination campaign in the country. And most of the people will have a lot of queries. Okay, so regarding whether I can take this, whether it gives protection. Okay, so and who is monitoring this? All these questions normally raised, and we have to answer these queries. Then only I think we can build vaccine confidence. Okay, so what was lacking initially? There was a lot of people were confused, and a lot of queries are not answered, and a lot of vaccine hesitancy was there. And now I think now we are going for vaccine confidence. Okay, so once I think all the things are clear, so people have confidence to take the vaccine. Okay? And March 2020, and now we are in just completed 1 year, April 2020, and now we are in May 2021. So WHO declared outbreak as a pandemic. Has it impacted the health system, economic and social progress globally? Not only one or two countries. Okay, so almost more than 26 countries affected by this problem. And all these cases numbers are huge. Okay, so deaths are huge, and it is increasing. And government of India had a lot of guidelines, quarantine measures. They're all comes under the public health intervention, and newer diagnostics came, newer treatments came. Absolutely, there is no cure. We don't have any drug to cure this infection, and we were all waiting for most important thing, that was the key tool which is required to end this pandemic, that was the vaccine. And finally it came, and as we know, vaccines can prevent most of the infectious diseases. We have wonderful national program or universal immunization program. A lot of children, antenatal mothers, everybody was protected, and most of the bacterial and viral infections, most of the children were completely protected. Okay, so sometime for even lifetime. So because what this vaccine does is either it not only protect the individual, it protect even unvaccinated because of the herd immunity. And as I said, numbers are, I think initially, if you see number of cases, okay, so top 5 countries, America had a problem, India became second. If you see even death, okay, so we were there in the third. So as I said, number is increasing day by day. So very interesting thing is lot of manufacturers. Okay, so I think they very courageously. Okay, so they thought this is the right time to help people and manufacture vaccines, and so that we can prevent all these complications. Okay, so prevent all these infections, okay, so, and prevent this and make corona-free country in the world. So more than 292 candidate vaccines were in the clinical stage, 69 candidates in the clinical trials. As we've seen our India, okay, so 3 candidates vaccines are in preclinical stage, and 6 candidate vaccines are in clinical trial. So I think very interesting thing here is the very various platforms were used to manufacture the vaccine, starting the inactivated vaccine. I think Pfizer went for mRNA vaccine. Okay, so then vector-based vaccine, I think DNA-based vaccine. So under different platform, manufacturers started producing the vaccines, and most of the vaccines are very safe and very effective. Normally, as I said, vaccine preparation takes a lot of time. It has to go through so many stages, like preclinical studies. Especially we have to do some experiment in the laboratory, maybe using some of the animals. Then I think we have to go for clinical trial 1, then clinical trial 2, and clinical trial 3. So normally in clinical trial 1, they have very few participants. maybe 8 to 10, just to assess the safety. Phase 2 clinical trial, 50 to 500 participants were tested, and it is mainly for vaccine immunogenicity, so whether it is protective or not. And phase 3 clinical trial, okay, so it is mass, okay, so maybe 30,000 to 50,000 participants are involved, and it's mainly testing actual protection offered by the vaccine. And WHO was very clear. Okay, so normally any vaccine, so we have to choose for almost all the ages. So at the moment, less than 18, okay, so they are not there. Pregnant and lactating mothers not there. Sure, in the future, definitely they will also come into this vaccination coverage bracket. And normally, vaccine should not have any contraindication unless otherwise there is major indications. And efficacy normally we expect more than 70%, but currently most of the vaccines have this type of efficacy. And the next question is duration of protection. So normally during pandemic, okay, so because of the short period okay, so normally we expect protection at least 1 year. And safety and reactogenicity, okay, so this is also an important issue. So this is normally preferred, and we can, whether we have this minimal standards, so I think most of the vaccines will have. As I said, different platform vaccines came to the market. So one is virus vaccine, they are in activated form. That viral vector vaccine, so mainly by genetical engineering method, and nucleic acid vaccine like DNA, RNA vaccine, and the protein-based vaccine. So if you see all this platform, main key is spike protein, okay, so which is there in the virus. Okay, so that is the main tool, that is the main target, and according to that, they have this different platform and manufacture the vaccine. And already in India, we have already government of India has approved. One is Covishield and second is Covax. So both are a very good vaccine. Both are very safe. Okay, so as of now, I think many states, okay, so they have crossed a large number of people are vaccinated, and it already proved that it prevents spread, it prevents infection, it prevents complications. So if you see our country, so 8 vaccines are there in the platform. Okay, so starting from Covishield vaccine, so we have a DNA vaccine, we have adenovirus vaccine, protein subunit vaccine. So most of the vaccines, I think they're all in the different phases of clinical trial. So Covishield and Covaxin was proved already using, and some more will add. Sputnik will add in the near future, and most of the other vaccines definitely, I think it will come to the market in the near future. COVID-19 vaccination, it was launched in India, 16 January 2021. So, and it was all in the phased manner. So there was always a question was raised, why not it is for all? Okay, so it all depends upon the pandemic situation, vaccine availability, and who is at risk. So thanks to the central government, and they said we will cover up first all the healthcare professionals and frontline workers. Then we'll go for the second phase, age 60 and above, and below 45 years, sometimes with morbidity, with comorbidity. And now I think we are going for phase 3, so persons age 18 to 44 years. And slowly I think we will cover, I think the trial is going on, so we'll cover pregnant and lactating mothers, and last even children also. So very systematic way, there is operation guidelines are there, very nice, and we can use this platform and operation guidelines in every district and every primary health center area. Things are very clear. Okay, so norms are very clear. What is required is mainly waiting area, vaccination room, and observation room. So, and who will handle all this, and so how you conduct this vaccination very smoothly. So by having very minimum number of HR there, okay, so human resources, okay, so managed by 4 vaccination officer and 1 person, mainly ANM or doctor or anybody who can inject vaccine, and one supervisor who will supervise all the activities. So all are very systematically done. Okay, so that is the one thing I think public should appreciate. So vaccine area, vaccine site, vaccine session, people are in the over working there. So everybody's responsibility very clear. Sir enters. Okay, so very future enters the vaccination session site and verify, does the verification. Okay, so then somebody will manage the management. Then somebody will see him in the observation room. IC materials are displaced, queries are answered. Very systematically it is done. And as of now, okay, so most of the healthcare workers covered in the country, frontline workers are also covered first and second dose. 18 to 44 also. Okay, so just started. I think even we have finished 45 lakhs. Okay, so 45 to 60 years first dose, second dose, and I think everything is because of this app. Okay, so all are in the digital platform. Most of the, as I said, the government of India approved Covaxin, Covishield. So both are liquid vaccine and 2 doses, normally 1 month apart, and it is always a 0.5 ml. Okay, so per dose intramuscular. So Covishield comes in a multi-dose vial, so 10 dose, okay, and Covaxin comes in 10 dose vial or 20 dose vial. So storage temperature for our country +2 to 8 degrees centigrade. So even some of the vaccines, especially US, requires -80 degree, but I think our country, okay, so as of now, these 2 vaccines, we can store +2 to 8 degrees centigrade. We have all the facilities, even up to the primary health center level. So it is mostly sensitive vaccine, and there is no vaccine vial monitor like other vaccines. So it is a multi-dose vial. So open vial policy, I think, is very clear. Okay, once you take it out, open it, and write the date and time, and discard after 4 hours. Okay, so that is the one advantage of this vaccine. So after the 4 hours, okay, so we can't use the same vaccine. So, and as usual, so practical purpose, ensure early expire and first out. So whichever you use first, okay, so and do the same thing and finish it up. And the COVID-19 vaccination strategy has been formulated as per the guidelines from federal government. So vaccines are developed using multiple platforms, as I said earlier, and we are not supposed to change. So if I take Covishield first dose, second dose is Covishield only. If I take Covaxin first dose, second dose Covaxin only. So people ask, oh, sir, whatever you have now you give. So I think it is very clear. So they're not interchangeable. Beneficiary must by using same vaccine product. Okay, absolutely there is no contraindication. So if you see the figures now, okay, so hardly, okay, so people, most of the people, the 90% they develop only mild, yes, and severe and serious, okay, so very very rare. So normally people who have allergic to the first dose, okay, so anyway it is contraindicated, or people, some people they normally they have allergic to some of the pharmaceutical products. Okay, so I think they can stay back for some time. Yes, sir. And anyway, pregnant and lactating mother. So currently, we are not giving. I think sure in near future, even they will also come in the vaccination bracket. And people ask a lot of questions, sir. I had active symptoms also. COVID, can I take? So I think you can wait 4 to 8 weeks. Okay, so after recovery, I am positive, COVID positive. Can I take? You can also once after recovery 4 to 8 weeks, you can also take vaccine, but only also hospitalized people. So once they recover, okay, so they can take vaccine. So later, otherwise, absolutely there is no contraindication. Okay, so 18 to 45 or more than 45, 50 to 60, 60 and above. Okay, so mostly they have only the minor adverse effect. So severe and serious are very rare, as I said earlier. So following content is not contraindicated for COVID vaccine. As I said, the person with the past history of COVID. Okay, so if it's positive, no. Anybody is having hypertension, diabetes. Okay, so this is also a contraindication. Even HIV patients can come and take the vaccine, even though they have immunodeficiency, because they are also protected. So this is again one more question asked by the public and especially blood donors. So can I donate blood after vaccination? Okay, so anyway, this also they made a very good standard norms. Okay, so blood donors, they can donate blood. Okay, so 14 days after receiving each or any dose of the currently available COVID-19 vaccine. So and you know during this pandemic, okay, so most of the hospitals are full, beds are full. People create a lot of hue and cry. Okay, so but I don't think so. We require such a hue and cry. So like any other disasters, confusions are common. Okay, so and normally uh, within a week or sometime months. Okay, so we will come to the time. So coming to the Covishield, so very safe vaccine. So again here target is S protein, spike protein. So what they do here is the viral genes inserted into the harmless virus, okay, so, and harmless virus vector carrying this coronavirus genes. And this is the human body, which create antibodies and increases the immunity, and so that he may not develop infection. Even if it develops, it may be asymptomatic. So sometimes it is symptomatic, but absolutely they won't develop any complications. So antibody production is very good after 2 to 3 weeks of the first dose. So then normally after the 4 weeks, 4 to 6 weeks, we recommend for second dose. Even after taking second dose, 2 to 3 weeks after that. Okay, so very good immunity, and the second dose is normally for the long-term protection. So as I said earlier, so number of doses Covishield is 10 in a while. Okay, so shelf life is 6 months, and it is always 2 doses, 4 weeks apart. And we have to maintain this vaccine at 2 to 8 degrees centigrade. And most of the health centers, they have this facility. We have ILR, deep freezers, ice packs. All this is not issue at all. So definitely, so we can run this program very smoothly, even at the grassroots level. Okay, I think people ask, okay, so whether it is safe. Okay, so we know now it is safe. Then people ask whether it is, what is the efficacy. If you see here, very nice slide. So people are totally confused nowadays. They say, sir, I have finished vaccine and 1 day, so more now, more than 1 month, and 31 days, 32 days, what to do, sir? Okay, so I think very good. So less than 6 weeks, it gives around efficacy is 53%, 6 to 8 weeks, 51%. 9 to 11 weeks, 60%, and more than 12 weeks, 78% efficacy. So this is what I think we have to inform the public. Okay, so nothing will happen if you cross 5 days, 10 days more. Okay, so after the first dose. So ideally 6 to 8 weeks, ideal for second dose, especially during the pandemic. Okay. This is the immunogenicity. Okay, so this is also important. If you see day 29, okay, so 93.7%. Okay, so antibody production. So day 57, 97.4%. So that is why I said, okay, so both vaccines are very good. Okay, so antibody production is almost 93 to 97%. Okay, so I have given the duration, first dose and second dose, and as I said, second dose will give the long-term immunity. So immunity is very good. I think it's also very good. Okay, coming to the safety data. Okay, so as I said earlier, I think it is mostly you see here, most are uncommon. Okay, so blood and lymphatic systems are uncommon. Okay, so metabolic nutrition disorder uncommon. Mostly common is, okay, so very common. There will be little tenderness after giving vaccination. Okay, so there is little fever. Some people may develop little fever, maybe on the second day. Some people may feel little tired. Okay, so this is very common. Okay, so injection site induration. Okay, so flu-like illness is very common, and even sometimes myalgia, arthralgia, but others are all okay, so very uncommon. Okay, so like skin subcutaneous tissue disorder. Okay, so it's uncommon. Gastrointestinal, so that is uncommon. Okay, so that is why I said, okay, so most of the people will have only the minor side effects, which is manageable and acceptable. And Covaxin, again, virus is selected. Here it is the activated, weakened or completely inactivated, so that it will not cause any disease, but it will produce antibody, both IgG and IgM. It also protects the person and boosts the immunity. Okay, sorry. This vaccine is a 20 dose. Okay, so it comes in the two multi-dose vials. Okay, so and this is, as I said, similar to Covishield. A lot of confusion was there initially. Okay, so people said, I don't want Covaxin. Okay, so I want only Covishield. But a lot of Covaxin doses were available in health centers, in the hospital, at all hospital, but people didn't come forward. But if you see the current situation, okay, so I can see entire road is empty, market is empty, but a lot of people waiting in a queue at 6 a.m. in the morning to take vaccines. So this is the situation now. If you see 1 month back, okay, so people didn't come forward. Okay, so a lot of reasons are there why they didn't come forward. So that is why I think now they have vaccine confidence. Initially, they had vaccine hesitance. Okay, this untoward events. Okay, so and most of the time So people will have a lot of other health issues. Okay, so, and nobody had any serious or severe life-threatening events after the vaccination. So this is mostly it is not causal. Okay, so this unfavorable unintended disease or symptom sign abnormal after finding. So they have only the minor side effects. So coming to the minor side effect, as I said, is only the pain and swelling or induration, irritability. So severe, normally they do not require any hospitalization. Okay, so but serious, anyway, I think it may cause death or sometimes they may require hospitalization. So this is very rare. So in the severe, they may have high fever, more than 1 or 2 degrees Fahrenheit. But we can manage both minor and severe at the site. So serious adverse effect only requires hospitalization. Okay. Every vaccination session site, people, and they have anaphylaxis kit, they have adverse effect following kit. So all kits ready, everything is available. Okay, so and I have visited more than 50 to 100 vaccination sites. I have seen waiting area, observation room. I have seen there all the standard norms, IEC material. People are very happy. Okay, so but only thing is, as knowledge sharing platform, we have to give them only scientific facts. So I think phobia is around 90%. I blame only because of the TV and false information. So what is required is only scientific information. Even after any disaster like earthquake, cyclone, okay, so what is required is only scientific facts. But today, what happening is social media or TV channels. Okay, so they are the one who, because of them, like we are having tachycardia, anxiety, a lot of things. Okay, so I am very clear. I want only the scientific facts. Okay, so not from this channel. So everything is there in the kit, anaphylaxis kit and the AFI kit available. AFI kit available in the health centers, hospitals. But if you are having schools and other sites, they have this anaphylaxis kit. I think measles rubella campaign was a very good example. Okay, so we didn't have any severe and serious event after giving measles rubella. So this is what we say always learn by experience. So I think India doing well in vaccination programs. Pulse polio, we have eradicated polio, smallpox, all because of the vaccination. So that is why we need public cooperate, especially during the pandemic. For other childhood vaccine, we have enough time. We can manufacture in 4 to 5 years, but during the pandemic, okay, so because of the situation and because of the less time, okay, so I think everybody has to cooperate during this pandemic. So as I said, only for if there is any suspected anaphylaxis, so everybody was trained. Okay, so they should have it. Normally it will be early onset and rapid progression. They will have at least one sign or symptom regarding to with respect to respiratory, cardiovascular, and dermatological. And even all this we can manage because most of the drugs are there in this kit. We have adrenaline, we have corticosteroid, we have IV fluids. Everything is there. So in the vaccination site, especially in the hospitals. Uh, Even the dosage, everything is clear. So, and we have, I think India's one of the strength is vaccination national universal immunization program. Second is highly trained ANMs. Okay, so you get in the government setup. So they are very good, extremely good in giving vaccination. So I think thanks to the people who trained them. Okay, and managing this serious and severe one. So normally we refer them to the hospitals, but everything is there. Details about the medical officers, which hospital, which ambulance. So everything is ready in the vaccination site. So that is why. So people can come aramse to the health center and they can take the vaccine and go. Okay, for any vaccination program, okay, so it may be the national level or state or the district level. So normally there is different stages of preparation. One is preparatory phase, second is vaccination, and the post introduction evaluation. So whether anybody had severe, minor, major, and any other challenges, any other issues. So this is normally done for monitoring and evaluation of vaccination session. So COVID-19 vaccine is a new and introduced, it is at a fast track. And I think we need cooperation and coordination from every side. So there are external monitors, internal monitors. Okay, so through WHO, through UNICEF. Okay, so these external monitors will do this monitoring of vaccination coverage and monitoring of the sessions. Okay, so observation, monitoring of this, all this observation of rooms. All this, I think they have a very good checklist, and they do this rapid survey and give a report to the state or at the district level. So what is required here is quality and preparedness and timeliness and completeness and accountability at all levels. So what India requires is, because of the larger population, we are doing in a phased manner. 1, 2, 3, we already finished. We are in phase 3 now. And once we cover all the age group, all the segment, so definitely vaccine coverage will more than 80%, and the country will be pandemic free, corona free. So once we cover all the age group. Newer vaccines for approval, Sputnik recently approved. So Johnson Johnson, it is a single dose. Okay, so Novax, so very effective against the mutants. And we are in now phase 3. So all because one of the things what we saw in second wave is, first wave we saw elderly more than 50, it affected more, and now we see more in the 20 to 30 years of age group. So according to me, it is because of their lifestyle. Those who had a very good systematic lifestyle, okay, so they were given attention to everywhere, their exercise, their diet, their work. Okay, so those who had a systematic life, they never had any issues. Only because of their habits, okay, so maybe alcohol, smoking, or obesity, a lot of risk factors, they had 20 to 30 age group. So then we are going for now phase 4 vaccination. We'll include pregnant and lactating women. So already clinical trial is going on. It's already proved that it is safe. There is no teratogenic effect. And phase 5, okay, so maybe we may cover all the children. Okay, so very energetic, very innocent. Okay, so especially now there is enough support from the parents, and they're all away from the schools. They are between the four walls. Okay, so I think very important group. We have to protect them maybe in the phase 5 vaccination, during vaccination. And a lot of challenges are there because when there is a pandemic and it is a mass campaign, and we have to include all the age group on priority. And there some people have comorbidity, some people have existing uncurable illness. And we have senior citizens, numbers are increasing, and adverse effect, as I said, is only minor. And media attention. So what I think, please share only the scientific fact. Okay, so don't mix up things. Okay, so real scientific fact can be shared. Okay, so with the media. Otherwise, what will happen is, okay, so this vaccine hesitancy will increase. So what is, as I said, what is required is vaccine confidence. Coming to the summary, so I just want to summarize. So pandemic is not yet over. 2 vaccine got approval, and Covishield and Covaxin. So thousands of people have received it. Covishield, I already shared about safety, immunogenicity, efficacy. So data is available, published, and it's available in public domain. Covaxin, again, safety and immunogenicity is already proved. I think miles to go before. So every stage, okay, so every department, government, private, okay, so volunteer organization, everybody has to work together and support. So health of the every citizen of the country is very important. And I know healthcare professionals, so everybody is contributing. Okay, so and we need our question here is vaccine availability. So there is a lot of confusion now. Okay, so demand and supply and the beneficiary number. Okay, so there is a little bit of mismatch. Definitely, I think within a few weeks we can manage that. Thank you so much. Hope we have very safe, and we will have pandemic free, corona free India in near future. Thank you very much.
Thank you so very much, Dr. Kamath. I think it was a very, very interesting presentation. I think it helped, as we expected at the beginning of your presentation, that it will demystify a lot of issues around the entire vaccination drive, and it certainly has. And thank you so much for sharing your knowledge, your experience. And I know this is the the as updated as it can get information on both the available vaccines, Covishield, Covaxin, and what from the efficacy point of view, and all other relevant issues, which from a layman's language, we encounter these questions during discussions with family, friends, even on the WhatsApp groups. But I think what you have shared has definitely brought a lot of clarity, and I'm sure all our participants, who are over 300 in number, second day running, would have learned a lot. It may seem very simple, something what they have read, but then coming from a doctor's, a practicing doctor's mouth, I think it adds that credibility and validity to the data and information which you've shared with all of us. And thank you so much for giving us the background, the existing scenario, and how one should look into this situation going forward. Really very, very, very informative, very thought-provoking. Thank you so much, Dr. Kamath, for your time and sharing your knowledge. Thank you. Dr. Ghosh, your comments, please. Dr. Ghosh, you're on mute. You're on mute. You have to unmute yourself, please. Thank you.
It is really fantastic and very much timely, with all details from a doctor's point of view as a specialist, that Dr. Kamath has very nicely elaborated the pros and cons, and which is to be taken, which is not to be taken, and with all specific parameters that he has shown in the slides. Even for a common people also, it is really worth to see and go through these things. In fact, this is also available in our YouTube channel. Parallelly, it is going on. So we have been forwarding this YouTube channel also, many of the WhatsApp group also, so that they can see the details, and especially with the highlight Covishield or Covaxin, and anyone can be taken, but not mixing up what he has really specifically mentioned. It is not mixing up. And also timing, and what are the efficiency, and what are the database, and the minute details, that it is a worthy presentation of the wonderful time at this time that Dr. Kamath has divulged upon this common topic that which entire world is going through. So I would say that it is really fantastic. And also I would also say that this many things that people are looking into, especially that which he has recommended, that in fact Covishield or Covaxin and symptoms that we are experiencing, which from the clinical point of view, he has indicated what are the kind of symptoms that may be arriving, which many of us we have taken. He has also listed out all those things. There may be pain, little bit, or fever, or something like that, which should not be mixed up with normal, say, virus effect. So, which he has also listed out all those things very nicely. So, and also giving a scope for research into taking into all these symptoms, which he has again indicated that what is after taking the vaccine and after fighting with whatever that things are going on, there should be a coordinated research and database keeping about the symptoms, and which is are being taken up, and our researchers should take care of these things after taking the vaccine, which is not the only way to prevention, even though it has shown a very big he has given again example of that also, in which are the cases, polio and other cases, that we have got a almost 100% successful. But in this case, it is still in experimental phase. So let the people, and in the social media, let us say that it is not the end, and it is rather the lot of research items as well as interpretations are also involved. Yes. Thank you, Dr. Kamath.
Thank you. Thank you. Thank you, Dr. I will, before I move on to Sarabjit ji, very good afternoon, Mr. Sarabjit Sota. Thank you so much for joining us, sir. He's the emergency specialist at UNICEF. And I'm also happy that both Dr. Ghosh and Mr. Sota are apparently in the same hotel property, which is facing the which has a forest view. So I don't know your room numbers, but I'm sure you are on the same floor with the same view, which is very interesting. I wish I had a similar view sitting back here, but then good, you're sending good vibes to us. Thank you. Thank you so much, Mr. Sota, for joining us today afternoon. It means a lot for you to, for you to take out time and be with us. We have over 300 delegates, participants who are connected with us from across the country, and some of them are also from across the borders, Nepal, Bangladesh, Sri Lanka, and even the Arab countries. So yes, we have in our way gone international also in last 1 year. The partnership which we signed with NIDM last year, just during when the COVID lockdown had started, and when the industrial event happened at Vizag, that's when we actually went full throttle to develop better capacities, help industries develop better capacities, especially from a restarting of industries point of view. We propagated the NDMA, issued guidelines also. And from there, the journey started. And till now, this is our 10th online training program. We've done a series of webinars and, of course, e-conclaves on earthquake, on cyclone mitigation, and what all and what not. And I think you've been a part of a few of them, Mr. Sota, yourself. So thank you so much again for joining us. Before I hand over to you for your presentation, ladies and gentlemen, a brief introduction of Mr. Sarabjit Singh, who's the emergency specialist at UNICEF, a highly accomplished, results-driven leader with over 25 years of progressive experience in steering risk-informed programming to achieve results in the domain of emergency preparedness for response, disaster risk reduction, climate change adaptation, urban DRR planning, and safe construction. Merit of being associated with UNICEF and other frontline humanitarian agencies, one of his key accomplishments is the assimilation of sectoral knowledge and programming skills on WASH, public health, social sciences, and human settlements to effectively advocate for linking humanitarian and development programming to achieve sustainable results. Mr. Sota brings practical skills in development diplomacy, organizational development, policy advocacy and communication, risk-aware development planning, resource mobilization, result-oriented monitoring, evaluations, and teaching learning designs. He's an alumni of International Visitors Leadership Program. In recognition of the humanitarian response to emergency work, he was included in the IVLP 2005 by the government of US. We are really privileged to have you with us. You've been a personal mentor as well. Thank you so much for joining us. Over to you for your presentation.
Thank you, Bob, and thank you to NIDM and FICCI. Both have been UNICEF's very, very valued partners, and we have always enjoyed working with all of you, and particularly with Chandan Bhai. And I not only share the same hotel, but I also live next door to Chandan. So I think we are also good neighbors.
Yes.
Excellent. It's a privilege to be part of Chandan's program because he's so scientifically sort of thorough in his work, and we love his style of working. So today I'll make a short presentation and then maybe open up for any question answers. So let me share my screen. Okay, screen. Do you see my presentation with a ambulance on the?
Yes. Yes.
Yeah.
we see, I think it's a Word file. We see
Oh, you
the
see a
ambulance
Word
footage.
file? No, you don't see a PPT?
I'm afraid not. It's a Word file, sir. But it has the photo of the ambulance, what you mentioned.
Oh, sorry. Okay, let me share it again.
Yeah.
Now, where am I?
Stop sharing and then again go. Stop
Since
sharing and then go to another file. Share
yeah,
again.
I'm unable to see it where it has gone.
Okay.
Stop sharing.
Akhil,
If I can have the presentation, I can run it from my side. If the
Yeah,
presentation
okay,
can be sent.
but you can.
Yeah. If you could email the presentation, Sarabjit, we can probably run it from our side.
Okay, let me try once. Now I can.
Yeah.
Should have been.
Now it is fine.
Yes,
Now
it is
the
the PPT now.
presentation.
Yes,
Oh, excellent. Sorry about this.
no problem.
That looked like a typical emergency response.
Yeah. Thank you. Over to you.
So, colleagues, all the participants across the world who joined us, I will briefly present my perspective of COVID response, and I might use some examples from certain cities, certain countries, but that doesn't mean that I'm sort of saying that these are the only good practices. It's just that I'm aware about those practices, and I'm involved in some of them. So the presentation includes I'll cover some fundamentals of emergency response planning. Then I'll try to eliminate the principles using some of the arguably effective practices. Then I'll go into the oxygen story, the complexity and the logistics of oxygen. Not that I'm an oxygen expert. I'm an architect and urban planner by formal education, so I have very limited understanding of it. But I think it's a topic which is very much on our minds, and in particularly in the second wave in India, it has played quite a bit on the politics, on the administration, on the minds of each and everyone. So I'll cover a little bit of oxygen story, and then I'll share a few planning tools and a possible structure for COVID response. So that's how it is. What you see in the picture here is UNICEF's response or support to Government of India on the vaccination program. So these are the sort of cold chain equipments being deployed in different parts of the country. So a huge amount of supplies have gone in. And from this, I know that what it means to gather supplies at this point in time. And we've been doing global procurements. It's a huge logistical exercise. And I think we've enjoyed our partnership with the Government of India to roll out the vaccine program, and was happy to see Dr. Kamath give us a peek into the vaccine program. So that's very much appreciated, Dr. Kamath. As far as COVID response is concerned, we many times invoke the war spectrum, and we use words like war, fight, war rooms, COVID warriors, and so on and so forth. And I'll not go into the right or wrong of it, but let's start with it and then see where we can go. So more than often in most countries, it's war against COVID. So if we were to respond to COVID through the analogy of the war, it's very important that we start thinking of logistics, because all wars are won or lost based on your logistics. It's so they say that amateur stock strategy and professional stock logistics. I'm going to give you 4 quotes from the military background, essentially. So this is one of the very famous ones. Second, we all know about Alexander the Great. He said that my logisticians are a humorless lot, for they know if my campaign fails, they are the first one I'll slay. So he used to them out if it didn't work out. So logisticians are so very important, and logistics is so very important. Logistics is less about having certain set of resources, rather more about their timely deployment where it is needed the most. So just having the resources has no big meaning. It's about judicious use, application, and then monitoring their effectiveness. That's the core of logistics. So logistics sets the campaign's operational limits, how big you can go, how deep you can go, how far you can go, how quickly you can expect results. Everything is dependent on what kind of well-oiled machine your logistics is. And today we're talking about a very complex operations. But I strongly believe that heroic narrative of mobilization of war only obscures the complexity of the situation. In mobilizing our response to the current crisis, we should not neglect the importance of planning for continuity of routine services and the wider socioeconomic activity and the socioeconomic recovery and so on and so forth. So everything has to go on together. So there are a number of domains within which we are, as a country, moving, and we have to weigh our priorities at different points in time and keep shifting our strategy and keep moving. Now, health system, which is at the center of this crisis, arguably, one might disagree that it's a public health crisis, so other sectors are equally important. But health sector per se is a very complex sector. And patient care, particularly, which has been in the sort of focus in the second wave, particularly, that so much of a highs, death rate, and so on and so forth. It's important that we understand that this complexity has the system has many factors to it. So the patient care factor, the service providers factor, the factors associated with it, just tasks, and millions of tasks to be performed just to manage this crisis. And the technology and tools factor, where probably oxygen sits into the first 4 of these. And then team factors, various teams working together, from paramedics to doctors to the hospital managers and so on and so forth. And then there are environmental factors and organizational factors. So there's a huge complexity in this. And as a system, we try to put put up a number of barriers to improve our performance in terms of defending our patients, our populations from the hazard which is the COVID disease. And like always, in any country, not only in India, each and every barrier which we put up will have certain deficiencies, which is represented here through holes in the cheese, the Swiss cheese. But we have to start, as Dr. Kamath was also saying, that we have, in emergencies, we have to start with what we have, and then systematically reduce the density of these holes, the size of these holes, and plug them one by one. So improve our effectiveness on the go. So we have to repair the plane which is flying at an altitude of high altitude. While it is flying, we have to repair it. We have to retrofit it. And that's the complexity of health system, which we are considering and we are experiencing in real time. Now, oxygen has been disproportionately, I think, given the visibility, and also it has come, it has run into lots of problems, logistical problems. But I was looking at some of these evidences that oxygen has never been a real point of focus for the health sector. And here are two evidence for the statement I'm making. You look at the WHO document on monitoring the building blocks of health system. Oxygen is not even mentioned once here. You look at the policy and procedure manual of Government of India on equipment management unit within health sector. No, everything else is mentioned but oxygen. So oxygen was never probably an important factor in the health systems. And it's just that because oxygen therapy is so important and central to COVID risk management, it just got surfaced so seriously in India particularly and elsewhere, I guess, as well. Now, medical oxygen usage is actually a very complex science. I've just given you one link here. You can go into it. It's fairly complex. Though we in practice we try to simplify it and try to use it the way we can. We trust that people who work in the ICUs and etc. know the whole of it. Let me give you a little peek into the oxygen story and its complexity in India particularly. 10 days ago, India's medical oxygen requirement was 7,300 metric ton per day. Today, it must have gone up. And it's increasing by the day. It may reach 10 to 12,000 metric tons per day very soon. And some people are talking about 20,000 metric tons. So things are not looking very good. We are converting industrial oxygen to medical oxygen, hence industrial usage has been suspended, which really impacts the industry side. And it's not very easy. Converting industrial to medical oxygen also is quite an intensive process. And then we're talking of distribution to 5,000 or more hospitals. Logistics of liquid oxygen at minus 83 degrees centigrade is a big challenge. You need cryogenic tankers, which are in short supply. We never had those many. Bottlenecks are at every step. Two key ministries are working on it. Family of Health and Family Welfare and Family of Commerce. So Family of Commerce is on the oxygen side, delivery. Hospitals are mapped for the requirement by both these ministries, and they're trying to address them. But a lot of on-demand hue and cry has been created. But fortunately, I think is a settling down with the mapping of requirement. So from demand, we have shifted to requirement. So that's a good example of how we fix the holes, reduce the holes in the cheese. Now, Delhi has been in the center of the storm, particularly on oxygen. And one of the reasons is that Delhi does not produce its own liquid medical oxygen. It is trucked into Delhi, and on the way, trucks do get diverted. So Delhi, though being capital, also struggles to get hold of its share of oxygen. 1 liter of liquid oxygen becomes 42 liters of oxygen when it's delivered to the patient. So it's very, very compressed. Safety, security is a big issue. Handling of liquid oxygen, we had accidents. The accident in Nasik recently was a serious one. And then there have been accidents across the world with this sort of intensive use of oxygen. I'll continue with this oxygen story one more slide and tell you that hospital-based manufacturing is often talked about, that let's manufacture oxygen at the hospital level, which is always a partial answer. It cannot be a full answer, but it is a good answer. Why I say that? See, in pre-2020 era, only 20% of the beds would be oxygen beds in a hospital. So, and the requirement of oxygen would be 5 liters per minute. So in such a hospital, you'll be using 100 liters per minute of oxygen supply at max. But COVID requires much higher level of oxygen. So it almost becomes 150 liters per minute. Further, now 80% of beds are oxygen beds compared to the past when we had 20% beds. So now the use coverage of oxygen beds has gone up significantly. So the same hospital which was running at 100 liters per minute is now running somewhere around 600 liters per minute. So a lot of changes have happened in terms of infrastructure, in terms of supplies, and people who know how to handle it. You need a lot more people. So a lot of human resources and logistics issues. Hospital-based oxygen generation plants, which are mostly PAS, pressure surface absorption technology. It produces oxygen at 93% purity. And such plants come with capacities ranging from 90 liters per minute to 1,000 liters per minute. Now, if you produce too much and you don't have the usage, then you might have to release it in air. And now that itself is a small hazard. So could be a big hazard if until unless we release it properly at a certain height with the help of a chimney. So these plants take time to get critical. So once they're critical, then you keep them running. Then they have their issues of maintenance, which is quite high. So a lot of, again, bottlenecks here. In general, a mix of liquid oxygen distribution by trucking and hospital-based PAS technology use is required. And that will be an important sort of way forward for us for next few months till we really fix it properly. Oxygen distribution by cylinders is a small but not a very efficient way of responding, and that adds to the complexity and also a lot of the things happened in the recent past in terms of black marketing and coding and so on. So oxygen is double that of PAS manufactured oxygen. Now that's a significant decision point. That where do you spend more? Would you like to spend a little more on the capital investment in PAS plants and then reduce the cost of liquid? So these are that adds to the complexity of oxygen story. Logistics companies with specialized cryogenic tankers are required. They are fewer in numbers. Their numbers are limited, and efforts are being made nationally and at state level to acquire more cryogenic tankers and also cryogenic tanks, which will be based in the hospitals. So I hope it gave you some ideas about the complexity and the required sort of logistics and handling and its usage. Now, as I said earlier, the response to pandemic is not only in the healthcare facilities. It's a large part of response happens outside the healthcare facilities. For example, what's our personal behavior, the hygiene, hand hygiene, the respiratory hygiene, and so a whole lot of personal responsibilities. Then there are shared responsibilities of cleaning, disinfection, and ventilation, and isolation, and quarantine centers, and vaccination, and then comes the healthcare. Those who aren't able to protect themselves with so many barriers, so they still land in the hospitals. So it's very important that to protect the capacity of our hospitals and the staff, the frontline staff, we got to be a little serious about the personal and shared responsibilities. Dr. Kamath at length spoke about vaccine. Got to be taking vaccine as much as possible, and that's going to reduce the load on the hospital system, the patient care system. And one of the enablers in this whole thing of that each and every strategy which is lined up here and not lined up here, maybe there are certain strategies which are not lined up here, has to be backed by communication, proper communication lines, and a feedback loop on whether it's working, whether it's not working, how do you balance it with other strategies, or how do you reinforce it. So all those kind of feedback loops have to come in. And emergency operations would always happen in some kind of a constrained environment. Even in the richest of the countries, there will be resource constraints. It's not going to be plentiful. And in many countries, it's a resource poor situation. So within that, you have to make some multi-criteria trade-offs. So you might invest more in certain strategies and less in other strategies, and also leverage the all society capacity, including private sector and civil society and so on and so forth. Leverage the capacity of whole of government, not only health sector. So emergency response in a resource poor condition will always have some level of trade-offs. And if we maintain transparency about these trade-offs and communicate them very clearly to all the stakeholders, they will stand up with the government, with the response commanders, and so on and so forth. But many a times, transparency, the information is not so readily available. Then people get suspicious, and then a whole lot of problems starts. So public health emergency is all about being transparent about information, and making the information available to different responders and different stakeholders so that the response can be targeted and shifts can be done. Uh, Gear shifts particularly, and you shift gears depending upon where we are in terms of emergency, where in terms of caseload, in terms of exposure. So it's very important that we focus a lot on information and information flow, communication, and the communication lines. Working in emergency operations, certain principles. Before you start your emergency response, think about public health, where whatever might be the emergency, whether flood, whether droughts, whether a real health emergency, whatever might be the emergency, think public health. And public health means toilet, water, shelter, solid waste, sectors, and application of standards, and then of course no one can do it alone. Think about stakeholders, the partnerships. So even before you set your foot on the ground, these things should be on our minds. Second thing, allocate about 60% of your attention to planning, command and control, mapping, lines of communication. It's very, very important. And about the rest of the 30% is on operations. Many times we believe that everything has to be operations, and what's the need of planning? Actually, for emergency managers, it's very important that we focus a lot on plans which are developed around wider capacity of the government, wider capacity of the civil society and the private sector and so on. So ongoing improvement, as Dr. Kamath was also referring to, is the core of emergency program. So you start and then you start controlling the rate of change of certain things. For example, you want to improve the testing. So testing has to go up. And the sanitization has to go up. And the case load has to come down. So a whole lot of criteria are there, which you need to control, different indicators and factors. And while everything you're doing, continually improving the line of communication between administration and the line departments, between government and civil society, between government and the citizens and men, women, children, communicating through different lines and different channels. But communication should never stop, and communication should always be two-way, and constantly update the stakeholders. That's about 30% of our effort. A small 10% should be allocated to longer term, because the short term should not come in the way of the long term, first of all. So work with a do no harm approach. And while one of the significant learning from the second wave in India is that while we are addressing the gaps and the short-term needs, it's very important that we fix the systemic deficits, particularly in the health sector, on the go. So while addressing the needs, you also invest in some longer-term perspective through innovations, through improved technologies. So we and also inspire a little bit. So it's very important that in such pandemics, it's very important that the system and the frontline workers remain inspired and empowered, and the ministries are empowered to deliver on their role and responsibility. Now, using an example from a city that's one of the largest cities of India, Mumbai, I'm going to look at some of the principles which we just saw. And people are talking about Mumbai's model of response. So what is it? It's actually very simple. So what Mumbai did in 2021 is that based on their learning of 2020, they retained some of the critical infrastructure they had created, particularly the treatment facilities, and then ensured that the treatment facilities are decentralized up to the ward level. So ward level in India is a smaller unit. I'll show you in the city map. So each ward has its own set of treatment facilities, not one, two, but a set of treatment facilities. And the war room, going back to that old terminology of war, the war room is at the ward level. So there are 24 wards in the city of Mumbai. So 21 war rooms of each and every ward handles the response at the ward level. And the additional commissioner at the municipal level is responsible for monitoring and broader set of top-down policy actions, etc. But now the shift from 2020 to 21 is that they have decentralized their whole response mechanism. And that's really showing up in terms of the quality. Everyone, from NGOs to individual families, men, women, children, they can call the war rooms 24/7, and systems can see what's happening everywhere. So there's a lot of transparency, and this has really reduced the anxiety amongst the citizens that they have the governance mechanisms very close to them. The war rooms, the ward officials are very close to them, so the responsiveness has really gone up. So all primary healthcare, secondary healthcare, and tertiary healthcare, all are working in sync. And environmental sanitation, particularly cleaning, garbage collection, etc., vector control, everything is being managed quite efficiently. But that has a huge significance for Mumbai, particularly for the fact that about 60% of its population lives in the slums and the informal settlements. So there, the main strategy is environmental sanitation. So that becomes your entry point to managing the COVID risk. On the other hand, Mumbai is reasonably doing reasonably well in leveraging all government response, not only health sector, but all sectors contribute to the response. Now, when we look at the map, you see there are these 24 wards here. So what they have done is that there are, on the next slide, I'll explain you how the war room works. But two key decisions. One is the decentralization of response, and oxygen supply has been centralized. So what they did was, based on their early experience of oxygen shortage in the months of March and April, they quickly did the assessment of all the facilities, the hospital facilities, private as well as government, and they shifted from demand-based action to a requirement-based action. So they mapped out the requirement. So hospitals would not be coming up with that we have only left with 2 hours of oxygen and so please help. No, every hospital has to stop oxygen requirement up to 12 hours. Now, if they're running out of oxygen more than say 11 hours or 10 hours requirement, then there is an SOS. It's a bigger benchmark, more decentralization of response and centralization of oxygen supply. So that's how they've done it. It's fairly systematic. The war rooms have their dashboards of real-time information. It might look like this in terms of beds and types of beds. So in the war room, 24 war rooms, each ward has a COVID response war room. Each war room works 24/7 with teachers and data entry staff working in 3 shifts. There are about 15 to 16 people in each war room. Each war room has at least one doctor on duty who will be able to talk to people who are calling. Some of them might need direct call with the doctor. So, and doctor advises various other actions there. A dedicated helpline with 30 lines, uh, 30 lines into one number in each war room. Each war room has access to a dashboard, as I showed you earlier. It works in real time in terms of beds and types of beds. Where are they in private hospital, jumbo facilities, and other facilities? So people, what kind of beds are these? If there are beds where people need dialysis or anything else, so all kinds of good granular information is available. The war room gets calls not only for beds, but also for testing, ambulance, or just some anxiety about the symptoms people have developed. So they are handling everything at a very, very sort of efficient manner. And this interface with the public is one of the critical success factors of Mumbai. The war room as an interface between citizens and the system, the health system. I think one of the key critical success factors of Mumbai are these war rooms. Now, final two slides. I just I'll not go into the details, but this is how I would suggest that one should do response planning, particularly for a public health emergency. It's exactly the replica of principles which I showed you earlier. So it's just converted into a tool. So use it, and any more information we can provide, please come back to us. I'll stop by saying that any emergency response should have a structure, proper structure. Again, using the war analogy, if you don't have your infantries and the other elements of signals and logistics and other elements of your war, then forget about winning. So there has to be a clear command and control, clear operations priorities, programming priorities, and in such a pandemic, you've got to be leveraging all society, the all government resources. So the structure has to be really well thought through. It has to be established. It requires a certain level of effort to establish such structures. It requires a huge leadership skill. Like any good emergency response, leadership will be the key, I think, ingredient in this. And coordination, collaboration, cooperation is what this leadership should be driving. So I've left this little Word document here, which has the response structure, and particularly this becomes very important that the next phase of our spread is happening in the rural areas. So we got to start implementing our district strategies very clearly. So establishing structures at district and sub-district level for a rural, handling the rural spread, and maybe the third wave, which might be more sort of attacking the younger generations. I think we got to prepare for this and act very fast. So I'll stop here. Thank you very much, Vicky, Rubab, and Dr. Chandan for having me here. Let me stop sharing, or this is stop. Okay, excellent. Thank you.
Thank you. Thank you. Thank you, Sarabjiji, for that very, very informative, very exciting presentation. I think a few key takeaways. I mean, for me, you really laid emphasis on the command and control aspect. This is a hard war situation, and how systematic command and control strategies needs to be implemented. You took a, you referred to a very important example of Maharashtra, especially Mumbai. And I know since one of the very dynamic bureaucrats who is now right now in the Health Affairs, Mr. Asim Gupta, who's the Principal Secretary, Disaster Management, Relief and Rehabilitation. I've had a very good fortune of working with him for almost 2 years when he was the Principal Secretary for Rural Development and Skill Development in Maharashtra. I would, with my limited and humble experience of working with various state governments, I think he's one of those people who can really make a difference on ground. So passionate about what he does. An IIT alumni from I think Kharagpur, if I'm right. Brilliant mind, and I think I've seen the change. In COVID, whatever you've mentioned, I think this is something which should be a template for so many other states to follow. And I think this Swiss cheese theory, I think this theory was only developed for emergency response and disaster management. I think it is so very relevant whenever such. And I think the way you've explained in your presentation, the personal and the social responsibilities, and how that theory fits in so well. I think brilliant, sir. I think very a remarkable presentation. I think a great learning for all the participants, over 350 who are with us right now, and I'm sure they're all. I can see it in my private chat also. They're appreciating what they've heard. Really, very helpful, very useful, and they want to get a hand on what you've just explained. But let me tell you, we are live on the YouTube channel also. Ficky's YouTube channel. It's there. It will be there. All the audience, you can share that link with your friends and colleagues, and then we will also try and share a presentation once it is approved by the presenter, along with the certificates which will be issued to each and everyone. Thank you so much, Sarabjiji, for that brilliant presentation. Your comments, Professor Ghosh.
Absolutely no comments. My family is enjoying your presentation, even though you live just next door to me. For the first time that I took the laptop to my family, and then we are all seeing that, and also sharing these things in our apartment WhatsApp group also.
Yeah.
So I think really super. It is really great and timely, and the kind of experience that you have shared, and which I have also shared the YouTube link to everyone in the chat box. So it is that is why during your presentation we can see more than surge of participation. We can see. It is super things up, and of course due to COVID we have not been able to share a cup of tea. But sure, let COVID is over, after vaccination phase is on, and post COVID symptoms that which are arriving in the name of happy hypoxia, or in the name of black what is that, fungus, or so many things are complications arriving, and we would sure see that vaccination is there, and along with that whatever symptoms are coming, and the emergency protocol that which are taken up by USAID with FEMA. Dr. Prusti, he was looking into this and telling or giving series of program through NIDM, as well as Lal Bahadur Shastri Institute in Mussoorie, that the incident command system, or incident response system that which is going through, especially our servicing bureaucrats and many other group of trainers that being made. I think Bombay has made a really live example where you have been so much meticulously involved. And thank you very much.
Thank you, and of course, many congratulations and compliments to the work UNICEF is doing in this country. So thank you so much for making that happen when it is most needed. And I think a big gratitude, big thank you from all of us to UNICEF and its partner organizations for making the difference on ground when it comes to this. Thank you, Sarojit. Thank you. Moving on, ladies and gentlemen, we have amongst us Dr. Ritu Priya Mehrotra, professor from the School of Social Sciences, Jawaharlal Nehru University. Thank you so much, Dr. Mehrotra, for joining us today afternoon. We've had two very interesting, intriguing presentations, and and yours would be no less. We are equally excited, and that's how the lineup has been. And all thanks to Dr. Ghosh. I think we're all part of the network. It's a huge family of experts now, and I think we all take the responsibility to come forward and help build better capacities, help better awareness, spread better awareness amongst all stakeholders in the society. And I think this is one humble step what FICCI and NIDM has taken together to bring the best of minds come together to generate more awareness amongst the common man. So before I hand over to you, Dr. Ritu Priyaji, I would just introduce briefly to the audience. Her qualifications include MB, BS, PhD in community health. Areas of interest and specialization include public policy formulation and analysis interlinking epidemiology, political economy and health culture, communicable disease control programs, nutrition and health, impact of public policies on health of migrant labor, the urban poor and Dalit groups, interdisciplinary health research methodology, holistic epidemiology, and her experience. It's something which needs no introduction, but she's a faculty member of Center of Social Medicine and Community Health at JNU since 1990, advisor public health planning at the National Health System Resource Center, coordinator of one of the 3 working groups of an European Union-funded project at CSMCH on monitoring impact of SAP on health in South Asia, coordinator of an accompanying measure funded by the European Union again on methodological issues in assessing impact of SAP on health in South Asia. She's organized series of webinars and also specifically a webinar on health technology, assessment choices and IPR issues was organized at NHRC in collaboration with Department for International Development and British High Commission. So it's very decorated and a very accomplished career, Dr. Priya. I would now request you to take it from here and make your presentation. Thank you so much.
Thank you, Babsood and Professor Chandan Ghosh for having me here. I hope what I have to say will be useful to you and the whole group. But I certainly have learned from yesterday and today. And I really want to thank also Sarojit Sahota ji. What he has done is really made my task so much easier, because I was looking at health systems development, and he's already explained much of the complexity of health systems development and flagged many of the issues that I will want to discuss. So it'll probably save me some time, and I'd move more into looking at the issues as illustrated from Mumbai, the issues that would now come when the rural areas become more significant in the pandemic and so on. I'll just share my slides and Is the PowerPoint visible?
Yes, ma'am, it is. It is. You can just put it on
Full screen.
full screen mode. Yes, please.
Yeah, let me try and do that
Yeah.
so that sometimes it gets stuck when you do that.
Right. Yes.
If this is visible and readable, Rubab, can I just continue with this?
Ma'am, you
I have
can
a
go
bit
on.
of
Yes,
an unstable net, and I find sometimes it becomes a problem.
no, I can imagine. I know what you mean, ma'am. It's okay. You can go on. I
Okay.
think this is pretty much
Yeah.
clear. I would also request Akhil. Akhil, do you think this should be okay, right?
Yeah, actually, I've zoomed this in a bit for the sake of our audience, but it is visible. I'm not sure about the other slides because I think there's some text on the other slides. So right now I can read it, but in the other slides, if it is text heavy, then I think we'll have to. If Dr. Priya, if you can go full screen, that will be great. If not, then this is fine.
Okay, then let's just try with this, and then we'll, if I need, you can let me know. Yeah.
Yeah.
Sure.
Okay. So as you can see, I just wanted to also explain that our Center of Social Medicine and Community Health is in the School of Science, Social Sciences, because it's an interdisciplinary center where we have half of us as doctors and half social scientists on the faculty, and similarly as students. And therefore, we look at public health and health systems development very, very much with an interdisciplinary lens. What I'll be talking about today is health systems development approach for COVID-19, specifically for the second wave. But we are clear that the first wave has certainly lessons, and health systems development does not happen without history, because as Sarabjit ji said, it is repairing the airplane while it is flying. Yet, as of now, between the first wave and the second wave, we certainly have changes which are posing greater and greater challenges to handle this. And I think we need to rethink some of our strategies in doing that. So that's what I'll present. I'm also doing this because, and I find this extremely interesting that after Sarabjit ji's presentation, you slot me there, because the questions that Chandan Ghosh ji posed to me were really in terms of raising the dilemmas and debates. It was about health system, wellness, accrued immunity perceptions, and where is the key for survival in India. The second question posed was scope of arranging more health workers or more congruent planning, which path to go forward. So these are debated issues and debatable issues. So I'll raise some of those, and I see them as not being mutually exclusive solutions. In fact, today, all out solutions, all of them have to be worked on so that we can get anywhere at all in this second wave of the pandemic. And yet, how we think about the problem itself and how to move towards solutions may be the game changer. So that's the title. Therefore, I've said paradigm shifts as game changers for the second wave. And as Sarabjit ji said, 10% at least should go to long-term thinking. That's the and more, because not only more waves of the pandemic, but also that these are the kind of occasions where health systems get more attention and maybe get long-term improvements as well. I just put this to explain to those who've not been working with health systems what the WHO calls the building blocks of health systems, to show that it's logistics is one part of it, but it is the logistics are situated in the framework of service delivery, the health workforce, which has to deal with all of it, the information systems, medical products, vaccines, and technologies. And we've heard so much about vaccines in the morning earlier. And then financing and leadership and governance, decision making, and so on. And these have all to be coherently geared towards improving access for all, coverage across the entire population, for us 1.3 to 4 billion people, and with quality and safety serious considerations. The outcomes being improving health, responsiveness, and improved efficiency, and so on. But this is where we'd have to think about how we move forward. And as I said, since that can only be built on what is already available, we'd have to very quickly look at the pre-COVID healthcare system, which I'm just bulleting some dimensions of it. Some of these may be very familiar, but for everybody, we have a mixed, sometimes called the pluralistic, public-private mix and philanthropic voluntary sector organizations, all of which provide healthcare, plural in knowledge content as well, which includes what we call modern medicine, conventional biomedicine as it's now called, Ayush with all the officially recognized traditional and other knowledge systems, and local health traditions, which is what people do in their homes and what community and folk healers do in their communities. So all this is what we have already available. And this in the public services network is a 3-tier system built over at least the last 70 years as we have it, but even beyond that, district hospitals and so on built during the British period. So what we have are over 1.5 lakh sub-health centers, 25,000 PHCs, 5.5 thousand CHCs, 34 district hospitals, and 539 medical colleges. And other than the sub-health centers and CHCs, the PHCs as dispensaries and the medical colleges are almost in the similar order for the Ayush systems. What this has meant for us is having registered medical practitioners, which amounts to 9 doctors, MBBS, 6 Ayush doctors, 23 nurses, plus ANMs for every 10,000 population. And that total together is what the WHO wants us to have as a standard. Therefore, in terms of human resource, in the country, we are not far off. But of course, we know 80% is in urban areas and in the private sector and so on. Major bottleneck, therefore, in the public sector is this shortage of human resources. And the private sector is not only these doctors and nurses, it's from the non-MBBS, what we call the Jhola Chhap doctors or practitioners, to single clinics, to nursing homes, to corporate hospitals, diagnostic services. The image of the efficient quality private sector generally comes from these corporate hospitals, but they're a very small part of the private sector. And I just want that, flag that. Then diagnostic services, home nursing services, and so on. But it's the largest chunk that we have of healthcare, with 80% of OPD and 60% of indoor care approximately being catered to by this private sector. And it's a growing sector. We have, fortunately and well built up, strong medical industrial complex of pharmaceuticals and biologicals, including vaccines, and equipment and insurance are upcoming areas in the country. Public financing has been the second bottleneck, which is lower than almost all the countries in the world that we'd like to compare ourselves with just 1.4% of GDP being reached. About between 30 and 35, after the National Rural Health Mission, that is reached about that much percentage of all health expenditure in the country coming from the public exchequer. But that leaves an out-of-pocket expenditure of people very, very high. Catastrophic expenditures are known to push 4 to 5% of our population below poverty line annually. And this out-of-pocket expenditure, 70% of it is purchase of medicines. Lack of public and private sector coordination, including regulation of quality and pricing, sharing of data, these are all issues that plague our system and have been there for some time. And the people managing systems are cognizant of them and attempting to do things about them, but they're very difficult situations to deal with, really. Now, with all of these as resources and with their shortcomings and their strengths, what we got in the first wave and up to April is data which gave us the complacency that we've done well, because we had done well. We had done much better than the large open societies that one can compare ourselves with in the first world. And so this is just a table which is showing you from an article that I had done earlier, which is showing you the comparison with USA, Germany, and Sweden for our infection rates. And our infection rates in December, January were higher than any of the others. So we'd had a very strict lockdown, but what we had is higher spread of the infection, and yet our positivity rate, test positivity rate, was 5% lower than any others, even though our testing rate was the lowest, almost 10 times lower than the US, 5 times lower than Germany, 5 times lower than Sweden. And yet our positivity, so we certainly did have less of a conversion from infection to cases. This was something which needs to be noted and epidemiologically understood, because the reasons for this are what we should attempt to replicate. The death rate was even lower and lower than all the countries that I've just compared us with, 1.27%. And therefore, this cannot be because of the medical system, because our medical system, anybody will agree, is not a patch on what these three countries have. So I just wanted to highlight this epidemiology of the second round and say that this is where we had reached. We'd had a healthcare system response with a certain idea in mind. The idea was of flattening the epidemic curve by imposing lockdowns, so that then as the cases get delayed and the peak of cases is smaller, the health services will not get overwhelmed. It was not necessarily to decrease the total number of cases by the end of the pandemic, but as health services are therefore able to get strengthened and provide services better, it is also hoped that it will turn out therefore in better health outcomes as well. The lockdown that we had did certainly slow the spread, and preparation of services also happened to a very large extent in the first year. Public health personnel doing tracing, tracking, testing, isolation of cases, very well in some states, not so good in others, depending on the capacities of the state and its primary level services. This is all done by primary level services. The testing is where the laboratories and the higher level services, especially the laboratories with that capacity come in. But the tracing, tracking, and isolation are completely primary level services. Beds were increased in existing hospitals, new facilities built overnight, and very innovatively in open spaces, in train bogies, community halls, etc., as per need. And by the end of it, we had excess of them as well. So all this was reasonably well done and well in time. It took a month or two to get to it, but we got there. Production of PPE kits and ventilators was initiated with an exemplary emergency response, especially of the textile and automobile industries, who dropped their other production and put themselves into producing the immediate requirement of PPEs and ventilators and so on. Medical equipment, medicines, etc. were also ramped up. So this is what we had as of December 2020. Now, what is the difference in this one? And I'd like to point very briefly to the epidemiology, which everybody must by now be familiar with. We've had virus variants and different ones across the country, which are some of them which have seemed to have spread in many parts, created a even faster spread than in the first round. And We now, therefore, in the country have 4 times more cases than we had at any point earlier, and a commensurate amount of deaths. So the virulence is the same, but the spread is much faster. Case fatality rate remains very similar to the first round, even though the numbers are high. And of course, we've all seen the horror of that, as well as from the crematoria and so on. Now, the difference geographically is that it is in many more parts of the country, and 50% are in rural areas. The first wave being largely urban and initially middle class and with really international travelers and so on. So what is it that we're now looking at in terms of this pandemic? This is the International Health Metrics graph, where they show us this first part of it is the first year, December 20, and then this is where we are now. This is April 21, June 21, so the middle of this is May 21, and that's sort of where they estimate a peak. I've been looking at their methodology and so on, and the numbers that they're giving, and I think both for cases and deaths, they are almost being conservative. They've, from the reported cases, they've got multipliers because obviously we are not testing enough and reporting. And we know that the RT-PCR also has 30% of cases shown as false negatives. So with all of that, what they've done is this kind of a modeling projection. And then after the peak, how it will go are a low, a medium, and a high projection done based on how will people behave on the decline. Will they start moving out more? Will they stop using masks? And so on. If the behavior is on the wrong side, we will have something like, according to their estimate, cases which end up in deaths of this order. And I'll show it to you more, it's clearest there, so not to save time, but through these two graphs, they then come to this cumulative death. And this cumulative death at the end of September 21 is in these three possibilities. Where we are right now is somewhere here, where the upswing is clearly happening, and we are nearing the peak of the curve. But while the decline happens, the deaths will continue, and thereby we end up with either a 1.7 million deaths or a 1.5 million or a 1.4 million. Now, this is the nightmarish picture that anybody trying to handle a pandemic or an epidemic has. And then if we look at the modeling projections of others, while many of them are similar to what the IHME has done, this blue goes completely way above the others. That's the Imperial College of the UK, which gives us 60,000 deaths per day for this peak. But that may be, let's hope that that's not where we are going at all, and that IHME is better ground for us. Now, our placing our faith in the fact that now that we have the vaccine and we are ramping it up will help us in this wave. When I look at the epidemiology of it, it doesn't pan out. Vaccination today is completely essential and must be done so that the decline may be somewhat faster and third waves are dealt with much, much better. But from the data that this table shows us of different vaccines, which are here on this end, and their efficacy at preventing disease, a second column which shows efficacy at preventing infection, and for different strains of the virus, you have very varied positivities. And what you do, if we just go by the fact that with reasonably high efficacy, of all these vaccines, we need 8 weeks for anyone, if they start today, it will take 8 weeks to complete. And then another 2 to 3 weeks for that second dose also to take effect to have full effectiveness of the vaccine. That takes us into July and August. And that is those who start now, those by the time we cover populations, we are going to have more time taken. And therefore that time, if we go by their graph here, then this decline is already happening in August. So we are getting there, but as known for other diseases as well, when you start in a pandemic, a vaccine program generally ends up at the end of that wave of the pandemic or epidemic. And so what is it that we can now do to decrease this graph of deaths? To me, as a public health person and a doctor, saving lives is the one prime task. And therefore, in attempting to see how we can do that today, it obviously has to be on an all-out war footing kind of effort. And Sarabjit ji has already outlined some of that for us. I would like to look at, with these differences that we have, where we did better in the first round, much better in the first round than those countries. We were largely urbanly located with the epidemic and so on. And we had in March an urgency to control. But somehow by this year, we had got into complacency. And therefore, we started late. Now we are in that peak, in that upward graph very clearly. So what is it that we can do? There is today, in the first round, we had a very complete and the strictest lockdown that the world has seen. But now there is a hesitancy to lock down. There are economic impacts, and we know also on the most vulnerable sections, the kind of impacts. Therefore, there is a reason for that hesitancy. The vaccine availability, like I said, one is that if we do it now, it will still take time. And two, the supplies, as of now at least, are inadequate. So hopefully that will come and it will work. And so we are able to handle by the end of the pandemic, if things improve and third waves are dealt with much more effectively. But the strategy of tracing, tracking, testing, isolation, which was the public health prevention strategy in the first round, is no longer possible with the kind of numbers that we are seeing today. The IHME again says that about 41% of Indians are already infected by the present strains. So we are looking at certain numbers where we cannot be doing tracing, tracking. Testing, we can do to an extent, but our labs in many states are up to district level and not sub-district levels. Even in the city of Delhi or in other cities and metros where many of you would be, you would know the kind of problems that people are having, the way the labs are overloaded, and therefore it takes days to be able to get the sample collected and then get the results. So with that kind of overwhelming in the cities themselves, how do we see it working for that 50% of people in the rural areas? Government industry research partnerships which dealt with PPEs and ventilators and beds and so on is still adequately available. What is there of these PPE kits and ventilators has stayed adequate, and the cities certainly have a better situation with availability of beds, though oxygen has been the big gap. And I will not go into that. I think Sarabjit ji has dealt with it beautifully and more than I can at all even touch. In the treatment, several drugs have been repurposed globally and in the country, with emergency use being allowed, and then RCTs initiated. And as we get the results of the RCTs, the regimens are modulated and adapted and changed. These are all very dynamically changing situations. And this in our country has been done both for the allopathic drugs, as we call them, and also for Ayush medicines. The Ministry of Ayush has very serious, they also set up a national task force and have been watching to see that rigorous research is done for demonstrating and finding evidence for what works and what doesn't work. So while we are waiting for that, and as most of us know honestly, that our systems work on over medication and irrational use. That we see in this pandemic as well. And we're getting more and more statements from senior medical people on television and otherwise telling the public not to use certain kinds of medicines, not to go for unnecessary diagnostics and so on. But that's something that we have still to contend with. And healthcare personnel who have been working tirelessly now for over a year, they got a bit of a break between the two waves, but there is certainly burnout. They themselves have been COVID casualties, and there is high unmet need for human resources. It was there pre-existing, and it is still there. So I've just laid out the context of what the challenge is that we have from now till August, let's say. And that's the timeline. So it's the greatest emergency of a war we are in the middle of to ramp ourselves and our systems up. And I think for that, we can't do what we've done in urban areas alone. We need to look at the larger context in the country and deal with that and look for our own solutions there. So I've divided this into three parts, looking at very concretely the preventive measures, the treatment measures, and then the enabling things that need to be done, like knowledge management and financing and so on. So I'll just take you through 3 slides, and I hope I will not overshoot my time. What I'm saying here is that we have 2 kinds. In this pandemic, we have seen very obviously and naturally, there has been a global discourse, and the global community of researchers have come together at the highest scale, which has never been seen before. The way they brought out the nature of the virus, the vaccines development and so on has been because of the kind of openness to collaborate. And yet we see problems with vaccine supplies and so on because of some lack of coordination and collaboration. And yet what I'm saying now is that there are 2 paradigms within public health and health systems development as well. And we need to think which one will serve us well at this point of time. And I've just labeled them for the sake of very broadly classifying things, a global health prescriptions and a medicalized paradigm. In our context, I've said that we need contextual solutions which are national as well as may have to be modified locally, and therefore that flexibility. And instead of a medicalized paradigm, we have a wellness paradigm. Now, it might sound a little ridiculous when we're talking of saving lives, and in the middle of a pandemic, then one says we should talk about wellness and use a wellness paradigm. But I'll try to explain why I've used that term, and I would certainly like feedback and discussion after I stop. I'll go through. In preventive measures, we have the individual immunity boosting measures. We have the non-pharmaceutical, what we call the NPIs for suppression. So from vaccines to social distancing, mask, lockdowns, tracing, testing, isolation, and to preventive measures. And so lockdown and behavioral barriers is where it was. Now, I would contend that in the present situation where vaccines, like I just tried to argue, am I audible? I'm getting a message that there's a.
Yes, we lost your voice for just 2 seconds, 3 seconds, but you're audible otherwise. Yes.
Okay, then I'll just continue. Yeah. So we have from the Ayush and the local health tradition community, herbal immunity boosting. Yoga is something that is now internationally recognized, and these are both seen as important for not only psychosocial well-being, for controlling NCDs, which are the comorbidities, but also for boosting innate immunity, which is other than what the vaccines will produce. It is the resistance the body itself has for other than specific to a particular virus. The vaccine is specific to a virus, but this immunity is about the general ability of the body to respond. And therefore, one would assume if that happens, it would also improve the response to vaccines. So one would see that as an important component together with vaccination. It's not an either or, but it is certainly an extension of having a view which is only focused on vaccines as the saviors. And we've had some debate in the media and all as well about whether the herbal immunity boosting is only a tall claim and false and non-science, or is it actually scientific? I've been privy to some of that research, and I think it is scientific. It has not only the perspectives of traditional science, but combining it with modern methodologies and so on. There is a great movement forward. And I think we need to be looking at that seriously. Of the non-pharmaceutical interventions, again, in terms of how we understand it, social distancing is a term which came to us again from the West. And for them, it may not be that serious. But for us, social distancing has many other connotations in our cultural context and social context. Two, it is not conducive to psychosocial well-being, because we need to have caring connections. We need to be continuing to care for others and so on. And I don't think I need to belabor that point. Instead of a full lockdown, we have come to calibrated closure of movements. In the last phase as well, we saw red, green, orange labeling of districts and thereby of calibrated closures. So that's completely well taken. For testing now, as I said, since testing is not possible for the large number of cases that are arising today, how do we develop a methodology of treatment and management which is not based on having an RT-PCR or a RAT test in your report in your hand? Hospitals till 2 days ago could not admit a patient who did not have a positive RT-PCR test. And that systemically would have excluded 30% of the false negatives we know RT-PCR has. But today, even that RT-PCR is not necessarily going to be available to everyone or RAT. So I would, and this is sort of that 2 days ago, the government has announced that hospitals can admit without a positive test is very, very welcome, because of the suggested, what we use in public health, the term syndromic management. It means that based on symptoms, you develop on a very scientific basis of studying the symptomatology of a large number of patients. And on that basis, you develop the diagnostic criteria, how to divide them into mild, moderate, severe, and then each one of those categories gets their management. So you're not waiting for a test to start off being recognized as a COVID patient and getting whatever you need to get. So that's one thing which we need to ramp up much more, this understanding that it is syndromic management and not the test which is the marker. The second is we need tests for surveillance. Surveillance being where we need public health people need data for planning. They need to know where the cases are coming from, in what form, etc., who is getting infected and so on. But we don't necessarily have to. It's almost as if that's become a fetish, that we have to have those numbers. Without those numbers, how will we plan? And we need them for planning better. If we look at the table, I won't go back there, but that table that we also had a column on the testing rates. India had 1/10 or less of testing rate of the other countries. And yes, we had done better. So tests themselves don't get you better. We have in public health and epidemiology, again, methods by which correction factors can be developed to multiply the underreported testing rates that we have. And these can be done with small surveys and so on. We've already seen surveillance data of some states and at the national level, which all helps us understand and create the estimated corrections. So we don't need to keep focusing on and on testing and keep putting all our energies to ramp that up. What seems to me to be most important, based on not only the reporting that one is getting, but on the epidemiological studies that one has read across the world, and what colleagues who have been doing very systematic research in their hospitals on following cases, Dr. Matthew George of St. Stephen's being one whom some of you may have seen on TV and so on, being one of them. And he's followed several, hundred of cases from day zero to what happened to them every day and so on. And on that basis, we can develop our local symptomatology and how it works, which provides us excellent basis to provide medical support for home care and do it effectively. As Sarjeet ji said, in Bombay, they were available online to provide that support. But that needs to be ramped up all across the country so that people are not rushing around in anxiety and looking for something more in the present environment. It would be a game changer if we officially gave it as much eyeball and media attention as we are giving to the drugs and oxygen and hospital beds, because it would not only help all those, the 80% who are mild and mild to moderate cases, to allay their anxieties, but what it would mean is it would decrease the demand and the pressure on the other doctors and on the hospital system, and thereby help the hospital system itself also do better, and of course help those who are doing home care, and also be able to pick up the risk points and get them to hospital faster if they need it. So it's a multiple benefits that would come out of really ramping that up. Now, we don't want our hospital doctors to start getting into that at all. What we would need to do is ramp up getting a whole range of people. It's sort of getting all on deck. All on deck. There are several streams and sectors of doctors who are almost sitting at home, or nurses or paramedics. Those are the ones we need to call upon completely. And this is not a task which non-medical, non-professional volunteers cannot do. They need brief trainings. And those brief trainings can be organized if we are ready to do this all on deck kind of approach. So that's really what I can see is what we need to do at this point of time. Take from a bottom-up planning kind of approach where we're able to do this kind of collaborative role, as well as do coordination of this large scale. Now, similarly, for treatment, just as I said, for tests in this, the public health strategy needs to change. The treatment protocols themselves also need to be reviewed based on the experience that has been generated now over almost a year and a half. And what we have from that is clearly that the efficacy is of a very limited number of drugs, and yet the other drugs go on. So what we need is, one, how to get people to these different levels of healthcare, those who need just primary care, either physically or telephonically, the secondary level services, and unfortunately, in the first round, we have not used our PHCs and CHCs at all as locations of healthcare for COVID. That's losing out on infrastructure which we can use, and I think it's time we use that, because that is all that rural areas have. And therefore, building on that infrastructure with the differences that would need to be there for different communities, different locations, the healthcare paradigm would have to be not only focusing on hospital medication, ICU, but home care, primary level services, optimizing existing infrastructure, including all pathies, and psychosocial support and mental health care. That's the paradigm that I'm talking about here. In the clinical protocol, Again, these meticulous doctors working in hospitals who have studied each case to understand what would work best in that context have worked out low cost, low infrastructure need epidemiological rational regimens for monitoring cases to find out when they're getting serious, to do treatment which can be explained even to lay providers of healthcare so that home care people can get treatment in time. And thereby, this systemic support to home care needs professional attention and not just, and systemic attention to make it, to show people that it is not only, it's not just a compromise situation. Because you can't get a hospital, therefore you are at home. Because you can't get a doctor, therefore. It is that this is the best way to go for the first 5 days, if you've got nothing more than the mild symptoms and so on and so forth, but you need that backup support. And therefore, to have the confidence that you're doing all right, and therefore all that needs to happen. But as people move, these numbers cannot get into our hospitals, whatever ramping up we may do right now. Oxygen and steroid hubs need to get close to communities. Our traveling time from a remote village to even the block town to the district town may be too late. By the time we need oxygen and steroid hubs close to communities in rural areas, and creating these, as yesterday I heard some people talking about industry getting together with governments to create field hospitals in districts. That's the way to go. But with not only hospitals, I'm saying we need a lower level of service where we can get this as life-saving for the next few months. And then they are on call with specialists who can provide that backup of knowledge whenever it seems to be required. And this is not letting away the hospitals at all. They will still have more than enough to handle. But hopefully with this kind of a health system response, the pressure on the hospitals may become somewhat less, but it will require a war footing kind of effort. It will require all hands on deck. It will require doctors, nurses, paramedics, private, public, voluntary, volunteers who can do this kind of work all come together. And this will be possible only if we have a decentralized kind of approach, as Bombay has shown with wards. But in rural areas, we'd have to bring it lower down and closer in certain ways. So the enabling management that is required for something like this would again, we've relied till now on modeling data. And several analyses of that data have shown us its shortcomings and how it led us and gave us a wrong kind of impression and so on. Rababji, am I overshooting time? Just tell me if that is so.
You can quickly, you can just round it off.
Okay, yeah, I'll take another 5 minutes maybe. Would that be okay?
Yes, yes.
Okay. So there is what is called shoe leather epidemiology, which means you're on the ground, you're moving in the community, so you actually get a hands-on understanding of what's happening. And that modeling along with that is what would work. So you need these two streams of public health to be talking to each other. They're not at the moment. They seem to be in two different zones. Governance with like decentralization and district as the unit for creating this synergy, mapping all the resources that they have, all the research institutions, educational institutions, health manpower, what have you. A knowledge management, which till now what we have seen is medical specialists and hospital leaders leading the epidemic control activities. If I may say so, what has just been created as the National Task Force, again has these hospital leaders or those who are clinicians. I hope they are able to manage it well. I wish they would, because the country needs that certainly. But what would have been appropriate is to have health systems and public health experts. And we have enough of research institutions, etc., on the cards, and the dimension of behavioral. What the IHME curve did was made 3 curves based on the behavior of people. social scientists are the ones who study behaviors and could have told us how to improve the behaviors and make them more safe. But we are not involving them very much. So how to do knowledge management so we have square holes and square pegs and round holes and round pegs come together would be something that we need to think about. This is reiterating the fact that we need to be thinking of our own solutions based on looking at our own experience. And to do all of this, we certainly need more finances than what health allocation has been happening over the last several years, but even in the present budget. We need to ramp it up to from 1.5% of GDP to something like 5% of GDP. And that, if we can't do with a pandemic like this, then we're going to face healthcare problems in a continued way. And lastly, I'd like to end by suggesting something which comes from a history of 200 years ago of Europe. District and city level joint healthcare platforms. The post-industrial revolution, when epidemics of TB and cholera were ravaging the towns of Europe because the industrial workers had come in and were living there in the kind of conditions that our informal sector workers are living today. They ended up, and there were very insanitary conditions in the towns. They decided that they could work only if they developed this better health, and therefore the city businessmen, tradesmen, industry, civil society, and government all came together. And that's how Europe got its sanitized towns and the kind of public health that they did. So can that not be done today with the CSR that we have, with the large civil society that we have, and these providing platforms for local level, city level and district level, or even lower than that, business and traders who would be interested in improving the conditions of their own towns, of their own heart, of their own mandi, and so on, and bring that into the public sphere so that that can work for improving sanitation, hygiene, water and air quality, and provide some of that 5% that we need for medical care. So putting this across to this audience, I thought was something that sharing a bit of history and the possibility of something that can concretely be done in an urgent and emergent way right now, but could carry us forward. Such platforms can then carry into the long term. I think I'll stop with that. The last slide is only summarizing, saying that these two paradigms does not mean that they're mutually exclusive. It means that the framework with which we think has to be more local and using communities and all other resources, all of government and all of society kind of approach. And therefore that would mean that the kind of protocols we develop for testing and for treatment and so on would also have different options, and we need to very seriously look at those options. Thank you. I'll stop there and welcome questions.
Thank you so much, Dr. Ritupriya. I think I'm awestruck. I'm honestly, I don't have words to express, whatever we've experienced today, the three presentations, and they've opened up, our brains to a different level. As a layman, as someone who has been following the subject closely, but only on hearsay, I would say. But I think looking at the facts, what Dr. Kamath mentioned, and then Mr. Sarabjit, and you complimenting what also Mr. Sarabjit mentioned, and you took it to a next level. I think this bit of information is the real crux of what we are trying to deliver through this platform of online training. And I think it couldn't have been better. I think you really set the bar very high. Today the bar has been set very high, looking at the quality, the information which you shared. I think one after the other, I think if that is something, and I'm on my chat window, I'm getting a lot of comments for people, they want to go deep into what you have said, through a copy of your presentation. And I've also mentioned that they can revisit your presentation on the YouTube channel, because there was a lot of information, a lot of relevant information, something we would want to absorb as part of this training. So thank you so much. Dr. Ghosh, quickly your remarks, I think I just can't thank Dr. Supriya enough for being with us today. Thank you so much. Thank you.
Yeah, only just to say that Dr. Ritupia, that the way that you have presented, the kind of work and the things that you have shared, comparing what Western or medicalized system and Indian system, it is a wonderful comparison, as well as not mutually exclusive. That is the thing that really we have to research into this. We have to rethink into this. If we have not done, only 1-2 example like Bombay is not enough. Entire country has to take it. And of course, in bringing you here is not I am fortunate here. Rather, I feel obliged because of my friend, Dr. Kaushik Burman, who is a doctor and who respect you. Just you are his mentor, and he is the school friend of my wife, who is also a doctor. So that way,
Okay.
that I got really thrilled to have you over here. And it is all because of him and because you have given this wonderful deliberations on the subject. It has really made us really obliged enough to have you over here in this platform in NIDM and FICCI.
Absolutely.
Thank you very much.
Thank you so much, Ritupriya ji. Thank you. There are some questions which are there on the question answer window. If ma'am, you have some time, if you could just visit, just quickly have a look, if at all. We'll try and take those questions later on. Otherwise, we can mail it to you also, and you can answer them later. But there are some questions in the Q&A window. If you can take them up, that'd be really great. Thank you. Quickly now, Dr. Ghosh, I think Vasant Matsaga ji is on the flanks, and now I would like to call him upon. Thank you so much, Vasantji, for joining us. Sorry for that little technical glitch. I think we had your email ID wrong. So we are glad that now that finally you are with us, we can have you share your thoughts and your experience today with over 300 delegates who are connected with us. A brief, introduction of Professor Vasant Matsagar. Structural engineering, offshore structures, earthquake engineering, seismicity, and civil engineering. These are your specialities, right? Am I right, Matsagaji? Right. Thank you so much. And I think what you would be talking about today is something what and you've seen. You must have heard what Dr. Ritupriya also was sharing with us in her presentation. I think we are not only sticking to the supply chain management issues or the second wave issues, but I think this is an opportunity for us to as I've been saying, to build capacities amongst all the stakeholders who are present with us to deal with this situation, to understand this situation, this current situation, current crisis better. And I think this is a small humble step in that direction. So now I would request Matsaga-ji, you to please share your experience and your thoughts through a presentation. Over to you, sir.
Okay, thank you, Rubab. Am I audible? Okay, thank you, Professor Ghosh, for giving me a slot here to talk about some of our ongoing efforts being made with the Office of the Principal Scientific Advisor to Government of India. I will quickly dwell upon the Oxygen Mission India, a consortium formed by the Government of India, where our mission is to tackle the oxygen shortage issues all over the country. This is being taken up in association with the Office of the Principal Scientific Advisor under the scheme Innovation and Science at Bharat. I will quickly talk about what is our action plan, what strategy we have adopted, how we are executing it, what is the formation of this consortium of oxygen at national level, and then what kind of proposals we have solicited, and then subsequently we will move into the supply chain management, how to distribute the oxygen for the needy. Quickly giving the background under which we have put this national mission for oxygen in a context. As I have said, this is led by the PSA office, Professor Vijay Raghavan and his team. Earlier, we have seen that there had been some lack of communication between academia and industry And however, those small scale industries or startups coming out of the academic institutes, they used to feel challenges in making their products commercial, as well as the knowledge that is generated in the academia institute used to take some time to penetrate into the industry, whereas industry relevant research problems were coming little late to the academia. Now, there have been some clusters formed, and within those clusters, we are dealing with these problems, and oxygen generation and supply is one out of them. So the overall setup is based on three strong pillars: industry, of course, then academia and startup and MSMEs. And within the startups, we have certain challenges passed on, and those challenges are being tackled in association with academia and from the generous support of the industry players. So this oxygen project, it is to cater for the current need that the country has on the rising demand of oxygen, medical oxygen in particular, to support the hospitals in procuring the oxygen, giving the high priority to some of these manufacturers who are producing oxygen, and then how to scale up their current capacity, because the demand is very high, and relative to demand, the capacity of production of oxygen or extraction of oxygen is relatively much lower. How to address the logistic issues? For example, there are some states in India like Kerala where there is some additional medical oxygen available, or there is a surplus oxygen available, but then how to take it to the places where it is required. And finally, enabling the supplies to the extended and makeshift hospitals, those which are newly established during the pandemic, how to enable these supplies to those new hospitals as well. So in order to have these demands catered for, this project Oxygen has been launched, and it has been facilitating in ensuring some of the supplies of critical raw material, different kinds of zeolites, particularly the lithium zeolite, then helping to set up the small scale oxygen plants, either in some MSMEs or even at the hospital premises itself, helping to meet the current shortage of compressors in the industry of oxygen generation, and then ensuring the final products reaching to the hospitals, such as the medical oxygen through the compressed air through the cylinders, concentrators, and ventilators. So there are 7 incubator institutes which are involved in this national consortium of oxygen. IIT Delhi is one of them. Apart from IIT Delhi, IIT Kanpur, IIT Bombay, and IIT Hyderabad, these are the IITs which are involved in the consortium. And then apart from these IITs, there is IISER Bhopal and Venture Center Pune and CCAM Bangalore. Now, what is the role of these incubators? So these incubators are essentially the technical partners who are extending their technical help in ensuring that large amount of oxygen concentrators are delivered to the patients or to the households and hospitals. So the target that we have kept is to the households, we should be able to provide some concentrators, whereas for the hospitals, we have 2 options. Either we are setting up small scale oxygen extraction and supply plants, which can be directly connected to the ventilator system subsequently, whereas in some other cases, we are seeing if oxygen, compressed oxygen or medical level oxygen can be supplied in cylinders, and cylinder refilling plant could be set up either near the premise of the hospital or somewhere away, but then transporting the oxygen cylinders to these hospital locations where it is essentially required. Apart from these 3 medical oxygen generation and supply, the 4th one that we have taken up in this consortium is do it by your own oxygen generators type, which can be made in households. And that technology also we are making available to those who are interested in making their own oxygen generation plants. So in this call, the strategy that we have adopted is these MSMEs should be able to produce at least about 100 to 200 units per day, if not more. We have requested them to submit their quick short proposals, maybe in the form of expression of interest, and then we have decided the timeline that within 1 week is the turnout period. Within 1 week, they will understand the modalities involved, and the funds will be transferred to the MSMEs, and they should start working on the plant and giving their deliverables as committed in their proposals. And the timeline that we are talking about in terms of the deliverables is about 3 to 4 weeks. It means within less than 30 days, we are expecting that the first batch of either oxygen concentrators or the cylinders are ready for delivering to the hospitals. The kind of proposals that we have solicited from these MSMEs, essentially we ask them to let us know as to what, if they are already in business, if they are already supplying medical oxygen, what is the volume of oxygen readily available, what is their current manufacturing capacity, and what is the delivery timeline. Apart from that, we have also asked them to give us their projection, how they can enhance their capacity of oxygen production so that we can meet the high demand that is currently ongoing, and what are the funds required for enhancing the capability as well. Here, of course, we all understand that extracting oxygen from air or producing oxygen through some chemical reaction, as of now, is not a challenge. There is no research involved in that. So that know-how is already available in the open literature, accessible to everybody. Therefore, the focus here is not on the actual science of how to extract medical oxygen from air or otherwise. The focus here in these proposals is what is the commercial feasibility of the plant being proposed to be set up at a particular hospital premise or the tank refilling for the oxygen. The way we are executing this is like this, and I will spend a little bit of more time on this part. So we are contacting the CSR organizations through the PSA office who have some funds to extend from their corporate social responsibility commitments. Our consortium, we have requested proposals from the MSMEs, and then those proposals we are sending to another evaluation committee, which is independent of the consortium, for evaluating them particularly on the commercial scale. Now, if those CSR organizations, they can directly fund the MSMEs, they need not to go through the academic institute as such, then the CSR organization signs an MOU with those MSME which have been shortlisted through the evaluation process. However, if those MSMEs should receive those funds from the academic institute, then the selected proposals are routed through those 7 incubators, and then the incubators and the MSMEs sign the MOU. And that is how the MSMEs start receiving the funds from the CSR organization. Now, once this cycle is complete, then the MSMEs which are shortlisted, and so far there are 7 MSMEs who have already taken up this challenging task of producing large number of oxygen concentrators and cylinders. The next task that we have undertaken is to take those oxygen concentrators or cylinders to the hospitals and sometimes even the plants also. So of course, we need for that purpose the transporters, and we have roped in some of the well-known transporters in India to help us in meeting that logistics. The logistics then becomes important, that there is some supply available, there is some demand, and based on the genuine need of that demand, how to transport it from the source to the hospitals. So for that purpose, there is another team which I am leading, that is taking in consideration how to supply these oxygen concentrators and gas cylinders to the hospitals where it is really required, taking on board the transporters. Now we have essentially 3 stakeholders. We are bringing them on one platform: the demand agent, that is the hospitals; the supply agents, that is the oxygen manufacturers; and then the transport agencies such as the courier services, for example. Our team, we are developing an algorithm which will deliver this oxygen optimally, of course, in the shortest possible time and as much as possible within the least cost. Of course, if the money is coming from the CSR, then the government hospitals, etc., they will receive it on pro bono basis. Whereas for others, it will be on a discounted price, because here we are talking about essentially a life-saving activity. So for that purpose, we have developed a logistic, and we are in the process of launching this platform in a couple of days from now. So this platform will cater for the demand from supply, taking the transporters on board. Herewith, I would like to make an appeal to the audience here to help us in setting up the oxygen generation plants and supply plants for the hospitals, having set up some of the plants for refilling the oxygen cylinder at some pressure, manufacturing the oxygen concentrators and plant for the purpose of these either oxygen cylinders or for supplying the oxygen to the hospitals. Mostly we have seen in the literature that the pressure swing adsorption technology is suitable in this case, and therefore most of these industries, they are facing a shortage of zeolite in general, but particularly the lithium zeolite. And again, our consortium has taken up that independently to help the manufacturers of oxygen or suppliers of oxygen making available the lithium zeolite. Apart from that, we are also told that there is a shortage of the cylinders as well as the compressors used in these concentrators. Again, we are taking up that with the help of even FICCI is involved in that. So this is where we request for your contributions. Those of you who are in the audience involved in any one or more of these verticals. Lastly, we'll be launching this logistic platform in few days, and we make this appeal to the CSR organizations to contribute in any manner that they will be able to. You'll be able to reach to us with this contact information mentioned on the slide. Either you can contact the PSA office, or my contact information is also available here. With this, I quickly sum up my presentation, and I'll be glad to answer if there are any questions. Thank you very much.
Thank you, Professor Matsagar. Thank you so much, Vasanji, for your presentation. I think I must straight away start with thanking you and congratulating you for the work which the government of India, especially through the PSA's office, is undertaking under the O2 mission. I think it was the need of the hour. Such an initiative at the top level was needed to deal with this situation. And I think it unprecedented time, but I think the way government reacted to the situation, there were a lot of opinions of this could have been done, that could have been done. But I think what happened on ground, I think we must appreciate that. And today, sitting here in Delhi in the comforts of our homes, we know that, as a common man, we realize the situation has become better, has definitely become better, because what was happening last 15 days and today, your phones are ringing less, your WhatsApp groups are calmer now, they've calmed down. And I think, although we know the situation elsewhere, in other parts of the country seems a little grim, but that too shall pass, because we've gone through this difficult phase in the urban India, and now rural is the next challenge. But now we are at least, the task force is there, and what you guys are doing tirelessly 24/7, I think that's a big thank you from all of us. Please convey our gratitude to the top office. We have had the good fortune of working with Vijay Raghavanji when he was secretary, and also continue to work very closely with his office since he has taken over as PSA. Dr. Arvind Mitra, who's also part of the PSA's office, we work very closely with him also. We work with him, and I think some great minds, and I think PSA in itself is a great initiative. And that's something which this government has come up with. Scientific minds have the solution. I think we need to not only groom them at the beginning, but in the entire developmental process of a country. I think the scientists have a very huge role to play. And I think what you guys are doing is simply amazing. Thank you so much for that. Dr. Ghosh, I know you would echo these comments, but anything you would like to add to this, Dr. Ghosh?
I have all appreciation to Basant for keeping up to his commitment to the country. In fact, it is IIT Delhi first. His name was there in the proposal, which just 3 days back he was telling that only 4, but now I can see that 3 more have joined in that consortium. So that is a kind of dynamism that we have seen, and it is all appreciation to you as well as Principal Scientific Advisor's Office that who have taken this issue in such a quickly every day, every moment, every hour that you are getting and getting those proposals around 40 plus proposal, and I think this is the first time that country has ever taken such a dynamic decision making as well as even to the logistic, not only production with a pinpointing that what is the target, what is the time, what is the money, and also sourcing along with 6.5 lakh, I think MSME organization, MSME team through that MOU directly with CSR funds and all these things, the block diagram that you have shown, it is an eye opener for everyone, irrespective of whether we belong to academia or whether we belong to society or everyone. I think your presentation has given a direct shot to the extreme need for the oxygen for a particular case and the kind of dynamism that which is being shown over here to take this project on a war footing and giving the timeline along with the definitive protocol to reach to the commercial level. So that is really fantastic way that this in the last 15 days, I think this work was initiated, and I think this way it is salute to entire organizing team and all the institute, and there are so many CSR groups, and already India government has mentioned this thing CSR support bills and forwarded them even 2 years back. I think 1.5 years back. 2 years back, rather, it was said the CSR fund can be used not for only making or cleaning or putting poster or cleaning the say road or putting some kind of advertisement that this is clean under CSR activity. But India government has taken that CSR funds, which I think is more than to the tune of 50,000 crore per year, which has been allowed to take into research mode or even in disaster management response mode also. So that is the kind of, I think I would say that CSR funds which are available and private or whatever funds that we are using in various manner, they are being cordoned with to transmit to this obvious need for the country, that oxygen. To start with, probably with more challenges that as it will be coming for the country, or we expect for the third wave or fourth wave, whatever it is, the way that we have taken it up, I think it is phenomenal. And I wish that let us, along with all participants, let us see that, yes, with the need and necessity and the crisis all together, along with academia, industry, and our fund who are providing through the industrial, big industrial units, including the individual and philanthropist, and also the kind of funds that we are receiving individually from abroad, from our NRIs and everyone. So I think now a ball started rolling, and we hope that good time is going to come to relish that yes, we can really fight it out, and we come to it. Thank you.
Absolutely. Thank you so much, Dr. Ghosh. I think these are the moments, these are the initiatives, these are the times when we really feel that we are in safe hands, as a community, as a society, we are working in a direction. The government is focused towards the safety. And I think this is a message which is going out from this online training program, and we'll try and publicize it as much as we can. Be rest assured, but Sagar Saab, we will, you made a couple of pleas also during your presentation. We will connect offline and we will see how we can use our network at FICCI to really reach out and send this message across, broadcast it in a level that it reaches the right people. So, and thank you again for making that effort. We will connect offline. Dr. Ghosh, I think what Sagar Saab, a couple of things, very important things he mentioned. I think we can also, we will be happy to tweet them from FICCI's official handle.
In fact, I'd like to mention that tomorrow we are going to have a person that who is the main doyen of making oxygen and nitrogen supplier to many of the industries, Mr. Misra. He is going to tell that how he has been producing, supplying, giving, design. And so we'll have a real presentation from a person that who is doing these things. Producing oxygen and supplying to many industries and everything along with the plant and other things.
Absolutely. So I will tell you a very interesting thing, anecdotically, but Matsaga Saab, there were questions when there was the first presentation today by Dr. Kamath, then we had Sarabjit from UNICEF, then Dr. Ritu from JNU and yourself. We had questions all the way, and most of those questions were answered in the next presentation. So I don't know if it is just a coincidence or the way it has been placed, or and we have no one else to praise and thank but Dr. Chandan Ghosh for this. I think most of those questions which I wanted to take, I realized that they have been answered, and whatever was not answered have been answered in your presentation, Matsagar sir. So what the country is doing, should country have a unified approach? And I think your task force is the answer for that. And, so I with all due respect to all the participants, 300 in number right now, most of your questions I realize are answered. If they are not, please, join us tomorrow. We will again go through the list of questions because we are really, we've skidded past our scheduled time. But it was every minute we spent extra today was worth every second. I think it was worth more than what we can thank for. I think it is just a huge learning experience. Day one and day two, I think we usually take on to the social media once during the OTP, but with the quality of speakers, the quality of interventions we have, I think our management has decided that we should go every day and take out some cues and some important messages from this online training program and broadcast it through our social media channel. And I think a special comment from Dr. Devendra Khokhar. Dr. Chandan Ghosh is a real Chandan, great man, very well organized the session. So I think, sir, this sums it up. And there are so many compliments being showered by all our participants from all across the country and the region. So on that note, I would not take much of anyone's time anymore. Thank you so much, Dr. Ramachandra Kamath. Thank you so much, Basant Matsagarji. Thank you, Dr. Ritu and Mr. Sarabjit for your some thought-provoking. I'm awestruck for the interventions and deliberations you made today. Given us a lot of food for thought to think, and also feel safe that as a country we are doing a lot. People might criticize us to whatever extent, but we must appreciate the flag bearers who are really doing and putting their the duty for them comes before their own life, and I think we can't thank them enough in this lifetime at least. So thank you again, ladies and gentlemen. See you all tomorrow at 2 o'clock for the final set of presentations, followed by a brief validatory session we'll have. Again, a reminder, please use the same email ID to sign in tomorrow. We will be reviewing the attendance before issuing any sort of certificate for this course. As Dr. Ghosh mentioned, you have to attend all the 3 days to be eligible for a certificate, which will be jointly issued by FICCI and NIDM. So I think we can call it a day today. I think now, Dr. Ghosh, and we can till tomorrow. I think we'll say goodbye to everyone. Have a good evening ahead. Stay safe, stay home. We will keep doing these online training programs to make sure you don't have to venture out. You have something very interesting to do when you're at home, to learn something every day when you join us. So thank you so much. And let's, as I always say, let's contribute in nation building, in being a warrior by staying at home and not venturing out. I think this is the best national duty we can do today. Thank you so much, ladies and gentlemen. Goodbye.
Thank you, Ruwab.
Bye-bye.
And also the team working in the background, that Manak, Barun,
Oh, yes.
and Akhil, and also in NIDM, Balaji.
Yeah.
And so it is the program that which came up in this way, even though we are overshooting the time by half an hour. Let us not take it as a usual way that, oh, Indian Standard Time half an hour late, but it is better late than missing such significance of such kind of gathering. And also I appeal to all the participants, as I said, that please, your laptop or desktop or whatever through which you are attending this program, since you are arrested by COVID in the home, please make this a homely affair to join tomorrow. We don't want to count in numbers, but we want to see that let this news as information spread to you in all echelons of our society to take our stride against this COVID, or rather to win the COVID Akraman by all might. Let us see you tomorrow.
Absolutely. Thank you so much. Thank you, Matsagarji. Thank you so much. Namaskar.